everyone. I'm Dr. Rashmi Vaidya. I'm a breast cancer surgeon with Ironwood Cancer and Research Centers. Today, I'll be talking to you about how to discuss or understand your pathology report, how to make sense of your pathology.
Patients these days are able to access their own pathology reports through their portals, whether it's with radiology or their own doctor. And sometimes these results are available to patients before even their own doctor has seen it. I'm here today to help you interpret and understand these complicated results because looking at your own path report can be sometimes scary. So here we have a core biopsy report for a patient, and what it is talking about at the top is the diagnosis, and it says things like which side, which breast it is, left and right, and then it gives the location of where the mass or the abnormality was found on the mammogram that was biopsied. And then the first words there are invasive ductal carcinoma, or sometimes it can be a lobular carcinoma. That just refers to what kind of tissue they see under the microscope when they look at the piece of biopsy. Is it arising from the ducts or the tubes that take the milk from the lobules towards the nipple, or is it coming from the lobules themselves? So those are two main different kinds of breast cancers. The next thing that you would see here is how many cores they saw, which is just how many number of pieces that were sampled at the time of biopsy. And then the next thing that they talk about is grade, which is speaking to the activity level of the tumor. It's between a 1, 2, and 3, 1 being the least active or aggressive, and 3 being the most active or aggressive. And then there are details about how they got to the grade, but the bottom line is to know whether it's a 1, 2, or a 3. And then it talks about many things within that frame, whether or not there was any invasive cancer there, or whether it was stage 0 or still confined to within the ducts, which is considered in situ, and whether it was involving anything else like a lymph node or going to a nearby blood vessel or a nearby nerve.
The next part of the report talks about what is called as the receptors. So it will talk about the estrogen receptor, progesterone receptor, and the HER2, which is a protein which is sometimes found on breast cancer cells. So if it says estrogen receptor positive, or it will give a percentage for how much of the tissue stained for the estrogen receptor, what it means that these hormones in the body, the estrogen and progesterone, are feeding this particular cancer to grow. So these hormones are helping the cancer grow. So what it helps us to understand is to know what are the pathways to treatment that can be used for this particular cancer. So in this case, blocking the estrogen or blocking the progesterone would be a good way to prevent the cancer from growing and spreading for this particular patient.
The next part of the report talks about HER2. This is a protein which is sometimes found on breast cancer cells. It is not very common. And what it signifies is a very particular type of breast cancer. If it is found on a particular cancer, then it means that we have targeted therapies which actually block that particular HER2 protein, and therefore they can be very effective in treating this kind of cancer. In this patient, the HER2 was negative. So in this patient, we wouldn't need to worry about treating her with HER2 blocking medications. So cancer treatment these days is very precision based, is very targeted, and we are very lucky to be here at Ironwood where we can deliver these targeted therapies to patients. So in this patient, when she had surgery and the patient chose a lumpectomy and a sentinel node biopsy, this is the pathology report from the surgery, and what that is showing is the lumpectomy that was done. Again, it cites the grade of the cancer. It tells us how big the cancer actually was. So the best way to know how big a cancer was is not usually at the time of the initial diagnosis with radiology, whether it's mammogram or ultrasound or MRI, because sometimes each of these can be just slightly wrong. So the final size can only be determined at the time of surgical pathology after the cancer has been removed. So in this case, it is 1.2 centimeters, and it is showing us that there was invasive cancer, which is stage 1, as well as stage 0 cancer that was present within the lump, but all the margins are clear. Clear meaning there is no cancer touching the edges of the margins. So that is important to know, because if it was not clear, or in other words, if a margin is considered positive, that means there was cancer going all the way to the edge of the tissue that we cut through at the time of lumpectomy. So if that were the case, it would require a discussion with the surgeon about whether or not a repeat surgery would be required to clear up that margin, to take extra tissue in that area. Remember, this is always a very personalized discussion between you and your surgeon. So I would discourage any interpretation based on this video or this information alone. This is a very individualized treatment. You must go back to your surgeon who operated on you for the breast cancer and discuss it with him or her. The next part of the report is talking about the lymph nodes, which are also evaluated at the same time that the cancer in the breast is removed. And this tells us whether or not there was any cancer in the lymph nodes. And luckily in this case, this patient did not have any cancer in the lymph nodes. Why would it be important to know that? Because it impacts treatment decisions again. So basically, the early pathology report when you get a biopsy and the pathology report that you get after surgery are basically giving a lot of very specific information about your particular cancer that is going to then help your treatment team to decide what is the best way forwards for you given the kind of tumor biology that they are seeing. Now let's look at a different kind of biopsy for a different type of cancer for this patient. So here is a lady who is 50, and she had a lump on her right side and also had an abnormal lymph node in that same armpit on that side. So she had biopsies of the mass in the breast as well as the lymph node in her armpit. And unfortunately, both of them showed the cancer. So there was an invasive ductal carcinoma grade 2 in the breast. And so just to decode that invasive means that this is a kind of cancer that is able to step outside the boundaries of normal structures like a normal duct or a normal lobule. And ductal means it is arising from the tubes or the ducts that carry the milk from the lobules towards the nipple in the breast. And grade 2 is speaking to the activity level. It's kind of between 1, 2, and 3. It's kind of middle of the way in terms of being aggressive. And the second part of the report is talking about the fact that they did see evidence of cancer in the lymph nodes. So this is important to know, because when a patient is presenting with a cancer in the breast that has already traveled to the lymph nodes, that automatically makes it at least a stage 2. And so based on the tumor biology, the approaches for this kind of cancer may be very different. So in this case, going to the next page, we find that this patient had a tumor that was not responsive to estrogen at all. So the ER or the estrogen receptor expression was 0, and the progesterone receptor expression was also 0, while the HER2 protein was overexpressed in this kind of cancer. So what that means is that in this patient's case, the estrogen and progesterone that everyone has in their bodies, even if they're postmenopausal, have not really been feeding the cancer in this particular patient. Also, she has a kind of protein called HER2, which makes the cancer be considered more aggressive. Now, thankfully, being more aggressive of a cancer in today's day and age doesn't mean it's not treatable. It just means that knowing that it's an HER2 positive cancers lets us immediately realize that we need to use those anti-HER2 targeted therapies for this particular patient, especially given that we have evidence that the cancer has in fact migrated to her lymph nodes. So for this particular patient, the way the cancer treatment gets mapped out is that we prefer to start with treating the whole body first with targeted therapies, anti-HER2 therapies, chemotherapies, and subsequently then come back to then resect the cancer within the breast. And sometimes, if we all get very lucky, about a third of times, when the time comes for surgery, many times we don't find there is any live tumor cells there at all. And if that were to happen, that would mean a really good outcome for the patient. But that's not a guarantee. That can happen sometimes for some patients. But for this patient, the treatment would be to consider first doing chemotherapy and targeted anti-HER2 therapy, and then followed by surgery, and then radiation, because we have evidence of cancer in the lymph nodes. Now that you know the ins and outs of the pathology report, I just wanted to caution you all to say that at the end of the day, your pathology report is still a very detailed personal document and really a treatment plan, a blueprint for how you can or should be treated. And that is a very important discussion that you should have with your cancer team. And so nothing replaces that one-on-one or multidisciplinary cancer talk that you have with your team. And I would encourage you to do that. Please take along someone that you trust for your appointments. Ask for a printed copy of your pathology report. And if you're going to Google it or chat GPT it, please look at peer-reviewed sites like nci.gov for your specific cancer stage before you approach your visit. Write down all your questions that you might have beforehand, and keep in mind that whatever you might read in your report is still something that needs to be deciphered with you as part of the team by your doctors. So I would encourage you not to read too much into it before you've talked to your own doctor. Take care.